Good afternoon, everybody. Good to see you all. I'll just wait another minute and then we'll get going. Thank you very much. Well, it's almost 1:30. Probably 1:30. Oh, a different machine tells me it's 1:30 as well. So I will take it as it's 1:30. Good to see everybody this afternoon. We've got sort of agenda items to go through this afternoon, and I've had apologies from Kath Byford, from Healthwatch Suffolk, and from Jude Bowler, and Hein might be slightly late in joining us, as somebody might, I think it's just Hein who might be a bit late joining us, but he will be here later on. He's got some family issues to attend to. Can I just remind everybody to keep their declarations of interest up to date? And can I just also say it's not just your own personal conflicts of interest, it's people who are connected with you, close family members. So there is a definition on the CCG conflicts of interest declaration form. So can you please check and that you have declared your own as well as anybody who are closely connected to you in the conflicts of interest. So I'm going to move on. Oh, before, is there any conflicts of interest, any items in the part ones of this meeting that's not already highlighted? No, thank you very much. So I'll move on to the minutes of the last meeting. I had a couple of comments from Hein on number 4 of the minutes. No, maybe it's page 4. So I'm trying to understand his comments. On item 4, sorry, on item 10, he is making a comment about right at the end, the bottom of the page. It says requested information for May, June, and July. But actually, he meant May, June, or July. And also he just wanted to put on the action log, learning from the data cleansing and possible ways of addressing it going forward. So that could be added onto the action log. And the other item was in regards to the forward planner. Actually, I think we can deal with this item under the finance paper, because that's what we discussed. I discussed with him this morning. Sorry, I should have read that before I started this meeting, but I thought it was simple, but I hadn't. Are there any other comments on the minutes from anybody from the last meeting? We're happy that they're an accurate summary. So apart from Hein's comment about instead of an and or, we're happy for that to be signed off. Excellent. And on the action log, we've got just at the moment just one item on there about the governing body, the terms of reference going to governing body, and that will happen shortly. So once that's done, we can take that as complete. And also, can we just add Hein's comment about putting the learning on the data cleansing on the action log so we can pick it up going forward. Any other comments on the action log from anybody? Great, thank you. And on to the forward planner. Sadie, do you want to just talk us through this?
Thank you, Doris. We talked last time about restarting some of these, given that we had been restricting business to essential items only. You'll see that we've got in red there the North locality update, and in fact all of those items are red. However, you will have a PCN development report today at a strategic level. So what we will propose to do is just restart those specific locality updates once we have started developing the plans with them for this year and looking back for last year's PCN development as well. And that work is currently starting to happen as part of our recovery and operational planning in response to the guidance that we received last month. So they should start again, but not ready quite yet.
That's great. I'm sure, you know, we will, in a couple of months' time, we should be back on track with some of these things. And it's just on the estates. I suppose hopefully by July we will get the estates update, because by then the returns from PCNs or practices would have come in and could be collated to have a meaningful sort of update on estates issues.
Yes, I met with estates colleagues this morning, and certainly the work around the estates strategy development with the PCNs and within localities is now starting again. There's lots of activity being picked up around the Wave 4B capital. So I think, yes, we'll definitely be ready to have a report at the next time it's scheduled.
Excellent, thank you very much. If we move on to the risk register, over to you.
Thank you. I've just prepared something on the 4 red risks that we've got, although obviously very happy to answer any questions from members or representatives on any of the other items, and also have colleagues around the table who may be able to answer some of the detail better than I. If I just highlight the current red risks that we have. PC3, which is the locally commissioned services project, you can see there that there is an update, and that we do continue to have some short-term capacity issues within our delegated team, but we've been making really good progress. In fact, even since the update was written around recruitment, we have offered somebody one of the roles today for a vacancy, and assuming that they take it up, which I don't have any reason to believe they won't, we will have only one remaining vacancy to fill within that team. We've already had applications come in for that. It doesn't close for another week. So in terms of the project itself, we've had really productive discussions with local medical committee colleagues. We've agreed the principles for the approach for this year for quarters 2 to 4, having protected income, as you will all know from last month, for quarter 1. And we're just working through the final detail of how that will play through for each of the localities now, with the aim of writing out practices over the next few days. The bigger project, which is from the first to be finished in time for the 1st of April next year, is yet to commence formally, although those discussions are ongoing internally about how we resource that and how we work it through. And a lot of the work that's already being done to go through all the numbers for quarters 2 to 4 will provide us with the foundation for the finance side of things for the next year. So obviously we'd like to be further along, but given the capacity constraints that we've been operating under both within the team and with the pandemic response, I'm actually quite pleased with where we've got to so far. If I go on to the next risk, which is PC 6, which is the learning disability health checks. One of the roles that we've recruited to in the team, who's will come in to replace the vacancy we have following Parveen's departure, is an LD expert. So really pleased about that. Currently working within the NHS England London regional team, leading their work on learning disabilities. So I think that will be very helpful for us as we move forward, and hopefully we can learn from him. He starts on the 1st of July. In the meantime, the peripatetic team that we have appointed as part of our pilot funding has started and have been working within the Norwich locality and begun to work with practices to review LD registers and support them in working with patients to bring them in for their health checks. And we now also have quite a lot of interest from West Norfolk locality practices as well. So over the next few days, we will start to move the team across so that they're now working across Norwich and West Norfolk. I've also met over the last couple of weeks with the quality and care team to look at the quality side of the learning disability health checks and how we can work more closely together to improve uptake in this area. The other notable change for this year, you'll remember we've constantly talked about the data being a real issue and not being timely. And as you know, we still don't yet have the final outturn figures from last year. The clinical quality reporting system, which extracts data nationally directly from practice registers, has changed from being a quarterly in arrears report to a monthly in arrears report, which is really helpful for us because it should enable us to be a bit more fleet of foot in terms of how we respond to supporting practices where there may not be the progress that we might have wanted to see. So pleased about that. And as soon as we can bring a position statement to the committee on that, we will. Moving on to PC9, this is the hypnotics and anxiolytics prescribing risk. You see there an update from Michael and his team that the dependence forming medicines meetings are restarting this month across the 5 localities. And the team is also working on the next iteration of the prescribing quality scheme, which will come to the primary care committee probably either June or July, depending on the launch date in July. But there will be a specific indicator in that on gabapentinoids, which again should help. PC 11, oh, I think I might have picked the wrong one up in my update. Apologies for that. I should have focused on the phlebotomy risk. Let me just tag across. Sorry, I'm working on one screen and sometimes difficult to navigate. The interface, apologies, the primary care interface with secondary care and other providers, PC 11. This is being led by the planned care team, and Fiona has taken the lead as the interface person in our team. the discussions are taking place with the acutes, and we understand that there has been contact made with local medical committee officers. Part of this is reviewing the national standard contract toolkit for primary and secondary care and the technical guidance. And obviously, we also need to take account of this in the recovery and operational plans, which have been drafted and submitted. And I think one of the good things this year compared to last is that the recovery plans are whole system recovery plans this time, whereas last year the primary care recovery plan was separated off and managed completely separately by the regional team. So I think it's really positive for us that we're looking at the recovery of the system as a whole and not just separating them out. So I don't have any further comments to make, but very happy to receive questions or queries with the support of my colleagues also around the virtual table.
Thanks, Sadie. Are there any questions, comments for Sadie? Karen?
Thank you, Doris, and thank you, Sadie. It's been really, really pleasing to hear the work that we're doing. And just to reinforce in terms of the meds management, just to say that the Quality Nursing Directorate is working quite closely with Michael's team, with Lois, also looking at how we can support practices. So some really, really good joint working going on.
That's great, thank you. Any other comments? No, I mean, I'm actually really pleased with your comment, your when you talked about the learning disability and the uptake from West Norfolk, because that was one of my questions, was actually, is the learning from Norwich going to be shared across the patch? So it looks like things are rolling out, which is really good. Do we know whether particular areas there is a greater percentage of people who have been on the learning disability register that we need to focus particularly on, or is it pretty even across the patch?
Well, we can certainly bring an update on that when we bring an LD position. I think Norfolk and Waveney, my understanding from information Parveen had previously told me was that there used to be more residential institutions in Norfolk and Waveney for people with learning disabilities. So proportionately, I believe we are slightly higher than other areas in terms of the numbers of people living in the patch. Whether that breaks down to individual localities, I don't have that to hand.
Yeah, I suppose it's just that if there are pockets where there's a higher proportion of the population, then we really need to focus to make sure that, especially, I mean, we need to do it across our area of responsibility, but it's targeting resources in the right places as well to get maximum coverage.
Absolutely.
John?
Yeah, thank you. Just wanted to ask Sadie about the locally commissioned services project, which was risk-free. So it's good to know that good progress is being made, and absolutely recognising the points you've made about capacity and recruitment to take that work forward. But just in terms of the kind of key milestones on that, are we looking to have something sorted throughout this year? So we've got a different arrangement in place from next April, or where are we headed on that?
Yes, yeah, that's absolutely right. And I think if we bear in mind the mobilisation time required as well, I'm really hopeful that by October we should be a good way through the project, and certainly LMC colleagues are very committed to this project and have brought in additional capacity to their team to enable them to respond to the programme and the work that's involved.
So just, if I may, just when do you think we'll have something that will just outline the programme to get us to April 22, then recognising the point you made about mobilisation, etc.? Is that maybe July time that there'll be a sketching out of it? Yes,
I think that's the sort of worst case scenario, that it would be July time. I mean, obviously it depends on how quickly we can get people into the team, and how quickly we can conclude the work on quarter 2 to 4. But as soon as that's done, then we can swing our attention towards the bigger piece of work. So yes, with a fair wind June, but failing that, it will be to the July meeting.
Thank you.
Oh, so you're saying June meeting, no pressure at all, Sadie. I was going to give you until July meeting, then you have the end of June to complete, but shall we hold you to that?
I will do my best, and even if I can't bring the fully mapped project, then I will be able to bring a sketch. And you know, we're really committed to doing this. The LMC are being incredibly supportive around making themselves available as well. So I think it's something that we all just really would like to get on with. But you know, we all know the capacity issues that have got a bit in the way over the past year.
I quite understand. I mean, it's and actually part of it is also understanding how different projects which might have the same label are slightly different in the delivery, and making sure that, you know, we are consistent across the patch as well in how we deliver services. Tracy?
Yeah, a different point. So just going back to PC11, so the knock-on effect of other providers not reinstating face-to-face services. So really pleased that Fiona's linking in with the planned care team about that. But I suppose because it links into the resilience of primary care as well, doesn't it? The fact is that expecting to do more and whatever. So just wondering if we might have more of a kind of a detailed report back on how that is and how that's working, how primary care resilience is looking, and what the effects are of other services. Because I think it's other providers not reinstating, but it's also reinstating things in a different way as well, isn't it? Because, you know, outpatient appointments, for instance, are not able to see so many people, and other services are working virtually too. So it's just how that all fits together, and perhaps something a bit more detail coming back. Would that be possible?
Yes, I can certainly have a conversation with the planned care leads around that.
Any other questions, comments for Sadie? No, thank you. It's really good to see progress. Thank you for that, Sadie. Moving on to the finance report. Jason, are you taking us through this?
Yes, thanks, Chair. Yeah, so the finance report today represents the full year results. They're obviously pre-audit. The audit is ongoing as we speak. But it shows a combined 1.1 million underspend, and the main component parts being 2.3 million overspend within prescribing, in line with previous reports, predominantly due to sertraline. We've included a more detailed analysis of the prescribing spend in section 7 of the report this month, following requests from previous month's committee. Also, local enhanced services had a net 1 million underspend when offset against the PMS GMS transition monies. This is predominantly due to the unwinding of the West treatment room costs, and again, this previously reported, been ongoing for a while throughout the year. And also, we've had a 2.3 million benefit from the unwinding of prior year items being realised in year. Moving on to COVID costs, there's been a slight increase in month of March, but the COVID costs still remain at low levels. This is mainly due to getting in the final claims before the year end, so we've seen a slight increase there, but no underlying increase in the COVID costs. GP forward view monies was underspent by 0.3 million for the year. That represents an underspend of 3.6% against total allocations for this area. And finally, just point on the financial risks. We'll be updating these future months reports to reflect the new financial year and the impact of the finances on the new financial year. So we'll have a complete refresh of those in the next month's reporting. Open up to any questions.
Thank you, Jason. Are there any questions for Jason? I had a question from Hein, which was in relation to the QOF figures, and maybe whether the finance report is the right place to pick it up going into the future, or we need something different. Was Hein's comment was that the actuals were 500,000 higher than budget, and he was kind of interested to see going forward what are the main drivers for the QOF, because I think from memory the QOF is divided into different practices can gain funding by doing different things, and whether there is particular areas that practices are doing well at and others are they doing less well at, and actually understanding probably the outliers, the ones who are doing really well and the ones who are struggling, right, rather than the 107 GP practices either by PCN or outliers. Whether we could have some sort of report on that at some point.
If we do a spotlight on QOF for the next month's report, I think would that cover it? I think
that could be certainly a starting point, and Hein's not here to defend himself, so
fair enough. I'll pick that up with Hein offline and make sure we include what you'd like to see.
I think part of it is actually understanding the components that make it up, and because part of the QOF is trying to encourage practices to do certain things for patient outcome, and if we can understand what is working and what isn't working, then maybe that's a better picture for us to get the handle on.
Yeah, that's fine.
Okay. Are there any other questions on the finance report? I think the LMC had raised a couple of issues directly, but I think you've actually addressed those, Jason, in your preamble, talking about the West Norfolk treatment rooms. And I think they had a question about serious mental health checks, that the money is going to be retained within the LCS funding.
Yeah, I believe so, but I can check that and take that as an action to respond to the next meeting.
Thank you. I think it will be really at some point in the future good to understand where we are in terms of primary care funding, because I think this year's finances is kind of, with COVID, there's been sort of the guaranteed income and also the additional top-ups for funding. I'm struggling to see what is our underlying run rate, and is the funding going forward going to cover that run rate, and I probably at the moment we can't get because the funding for this first half year is still in a different regime, but it's more understanding whether the underlying funding is sufficient to cover our needs, I think.
Again, we can do a spotlight to focus on the underlying position and highlight any key issues.
That'd be great. Thank you very much. Any other questions? Okay, we'll move on to the prescribing report. Michael?
Thanks, Doris. Yeah, so just the usual fairly simple prescribing report, but with a few things added because you asked for a bit of detail on what was going on with some of the quality indicators, etc. I'll just cover off cost first. So section 2.2, I'm pleased to say we've dropped down a place in the wider region from 4th to 5th in terms of spend per age normalized patient. So if you've got a higher elderly population, your spend is expected to be higher. So when you normalize for that, we've dropped down a position. It doesn't take account of deprivation, and as you know, Norfolk and Waveney does score highly on some of that. Not so pleased to say that our price concessions year to date, so to the end of March, was £6.2 million, which was a very big year for that. As you know, Jason's already highlighted sertraline, our anti-anxiety, antidepressant drug that that has heavily skewed that data. Going on to quality indicators, dependence forming medicines, as has already been mentioned, our dependence forming medicines working group is meeting again end of May. We're also talking to CCTG, I think it's next week, about system working to improve particularly hypnotics and anxiolytics, but also other drugs, antipsychotics, etc. We haven't changed positions on any of the dependence forming medicines indicators, and as Sadie noted in the risk register, hypnotics and anxiolytics is our area of concern. If you look at the graph, just to be, sorry, the trend over time below 3.2, you can see the trend line. If you close your eyes, you can see that the line is converging with some of our nearest CCGs. So in a few months' time, we should have dropped down a position or two, because most of the country is also reducing. So we're against a moving trend, but we are going in the right direction on that. So plan is in development for further work on this. A lot of the team and the quality team are involved in vaccination delivery at the moment, so it's a bit of a balancing act between priorities. But as we move back to business as usual, we're hoping to ramp that up. But certainly, as alluded to by Sadie, prescribing quality scheme focuses heavily on this particular area, dependence forming medicines, etc., and antibiotics and oral nutritional supplements, as raised last month. Interestingly, we looked at the early results of the existing prescribing quality scheme, which we will bring a summary to this meeting when all these submissions have been in by the end of June. So that may be July or August before we do that. But one of our indicators last year, just as an example, was looking at patients on powerful glucose lowering drugs who were possibly over-medicated because their HbA1c was quite low, and half of those patients were taken off of one of those drugs, which is quite pleasing, which should have reduced hospital admissions, as well as preventing symptoms in patients. So I'll bring some of the results when we get those finalised, as I say, as a breakdown of what we think we achieved with last year's prescribing quality scheme. But this year's one is just being finalised, and we're talking to various clinicians and the LMC about the indicators and the targets at the moment. And then when we're ready to have the finance agreed, clearly we'll bring that to this committee to discuss and sign off. Antibiotics, again, a plan is being developed. We've listed our outliers there. Again, the CCG infection control nurses are helping with this, and we've got an outline plan in forming, but again, as I say, slightly hampered by vaccine delivery at the moment, which is clearly a priority. Dietetic team activities. So we've done a quick summary. Anna Johnson's now back from maternity leave, and she's the lead for the service, and she's been updating various formularies and bits of guidance, which we're in the process of socialising around. And we've developed an indicator for the prescribing quality scheme. As previously noted, our spend did go up fairly significantly during COVID due to a number of factors, which happy to have some suggestions on why that is, but clearly the reliance on prescribed food may well have increased. So there's some work ongoing there because we are above England average, and the dietetic team are targeting practices that appear to need the most help first, as you'd expect, and doing some training with other practices using our dietetic assistants to deliver that. That's the summary. I'm happy to take any questions.
Thank you, Michael.
Okay.
Tracy, did you want to ask a question?
Yeah, a couple of really quick ones. So, in respect of the sertraline, it was obviously a major problem for the year gone by. Is that resolving for the year we're now coming up to, or is that likely to continue? Just thinking about what the cost is now and how that is. That's my first question.
Cost has come down a bit, but it's still quite a high and expensive option. So we have issued guidance. TAG updated the guidance to say please use other SSRIs if the choice is yours, for anxiety, etc. So escitalopram, low dose, and low dose citalopram are good choices. So that guidance has been issued, and it's been put onto the prescribing support software to suggest to GPs continuing to prescribe sertraline that that is a better option. The original NICE guidance said it was the most cost-effective anti-anxiety SSRI. Certainly isn't anymore. So it is still an ongoing issue, not as bad as it was.
Okay, that's good. And the other question in respect of the oral nutritional supplements. So I kind of looked at some guidance in respect of that with one of the dietetic team in respect of certainly working with people that are homeless and people with substance misuse issues. And I think we've had a little bit of pushback certainly from some of our acute trust colleagues in respect of kind of, you know, the quality impact assessment in regards to that. So just be interested in your comments on that really, because clearly we do want people to eat food and not have supplements, which is really important.
Yes, I mean it's been a long-term issue that drug seekers do tend to seek out oral nutritional supplements as well, because it is a free source of nutrition, and most GPs decline that because it's inappropriate. But and clearly we do have other options for patients on low incomes these days, rightly or wrongly. But yeah, we do discourage the use of oral nutritional supplements in our in that population, and there's lots of guidance around the country in various CCGs. I know there is a little bit of resistance to that. I mean, whether you regard it as disease-related malnutrition, or a personal choice to have SIP feeds, it's a bit of a social problem. Happy to for your comments, but it is a thorny issue.
Are there any other questions for Michael? John?
John.
Thanks. Hi, Michael. A couple of questions, if I may. So, just in terms of the overall spend and the chart you said, so we're improving slightly compared to where we were before, but we're still towards the upper end of the scale. So, do we compare ourselves to other CCGs to understand maybe where their spend, their activity, their unit cost is better than ours? And I suppose looking at the chart, Cambridge and Peterborough doesn't look that much different to us, but they're 5% lower. That's £8 million a year if we were to spend the same per head as Cambridge and Peterborough were, and they're not completely different geography, I suppose, and mix. So just wondering if there's any learning from comparing ourselves to elsewhere. And my other question, completely different, was to do with antibiotics.
Yes.
Conscious that this seems to have featured every year for however many years now in terms of ways to encourage practices to do things differently on antibiotics. What's going to be different this year, I suppose, or?
We're commissioning some training. So through the Workforce and Training Hub, we're going to do a session on antibiotics. So we've got access to either using Red Whale or Prescrip, and that's not going to be my decision who funds that, to see whether we can commission a bit of training and do some more audits against prescribing, because I think there's a lack of formulary adherence, certainly. So we've got the new formulary being developed, and that will be an online tool. So all the antibiotic formulary will be on there. So formulary.net will be out maybe in June, and the first thing we want to launch is the antibiotic formulary, so it's quite clear to everybody which antibiotics you should be using. Again, there's going to be audits in the PQS, but as we've alluded to, we hope to set up some sort of SWAT team, not dressed in black and wearing peak caps, hopefully, but who will be able to support practices who are outliers in this. Some practices in the past haven't been so keen on support as such, so it may be an opportunity to work with CQC colleagues just to highlight some of the outliers through that route as well. But I mean, clearly we're very keen on support, education, audit, change, encouragement to change through the prescribing quality scheme, and we'd rather do it that way. But I think, you know, there are some significant outliers on our patch, which we may well wish to escalate with your advice.
Bill?
I'm not a clinician, so if I'm asking a really obvious question, I apologise. But in the practices, it's not necessarily that would be a behaviour that would be common to all clinicians in the practice, would it? Is there a way of identifying whether it is an issue for the whole practice or a particular clinician?
It is possible to do that, and we have shared data down to GP prescriber level in the past. It didn't go down all that well with those highlighted at the top, it has to be said. So we normally just share by practice, but then when we go to do an audit or talk to practices, we will break it down to prescriber, and then it does become obvious which one or ones are choosing not to use formulary but would rather use broad spectrum antibiotics when that is perhaps not indicated. Yeah.
Because actually, if you look at the graph, you know, of the 17 PCN, 13 are over the average. I mean, some are, you know, much further over than others. So it suggests to me it's a sort of quite a widespread problem.
It does, yes. If you notice, the ones that are below average are the Grey Yarmouth and Waveney ones, which is where we've done the most work on antibiotics historically and developed our own antibiotic formulary. So we're trying to spread that kind of work and focus. Yes. So it is a historic thing to a large extent, and we've just got to tackle it. At the moment, I think things did slip during COVID because antibiotic thresholds was kind of lowered. If you're doing, as we mentioned before, online consultations, it's much harder to really truly assess a patient, and so the threshold at which you would give an antibiotic is significantly lower.
Is that going to you know, really change given the push to continuing with digital and remote consultation? Because it's a balancing thing that we need to do, isn't it? And if we're continuing, you know, to sort of do remote consultation, are we just hard baking the problem into the system?
I mean, it's not, the volume's not a huge issue for CCG. We've only got one PCN, West Norfolk Coastal, who are above the volume threshold for antibiotics. It's the choice of antibiotic. So if we can influence that and get that more appropriate to whichever antibiotic NICE suggests, then that indicator will come down quite nicely. At the moment, it is creeping up incrementally, mostly in the West. So the volume shouldn't be affected because I think we've done sort of most of the increase during the last year, but the choice of antibiotic is the key.
So I think we need to watch the space and hope to see downward movement.
Yep.
Thank you very much. Are there any other questions for Michael? No, thank you, Michael.
Okay.
We'll move on to the PCN update. Fiona?
Thank you very much. I will take the paper as read, but what we've tried to provide you with is an overview of where we are now and setting out the next steps in terms of PCN development. There are some key pieces of work that we are planning to do over the next few weeks, and we'll be able to bring you a much more detailed update. So the first thing obviously is to look back at what the achievements from the PCN development plans in 2020-21. Of course, recognising that a lot of the work and the workforce was refocused and reprioritised towards the COVID response, and the plans reflect that. The second thing we want to do is to refresh the PCN maturity matrix and update that, because that was last done in 2019, and we feel this would be a good opportunity to do it, look at it again. And as part of that, that will help us to and the PCNs to start developing their plans for 21-22, and those new plans have to be in place by the end of July. So we would aim to bring you an update on the first two pieces of work at PCC committee in July, if that is acceptable. I think the critical things for 21-22 in terms of PCN development, as it currently stands at the moment, plans are really only looking at the next up until sort of the end of September, is the expansion of the workforce and the additional roles. There are two new roles. One is the paramedic, and we've been having quite a lot of conversations with the East Anglian Ambulance Service about their rotational role. Of course, it's optional for PCNs whether they want to participate in that or to recruit paramedics directly. But we are making good progress discussions with East on that. And the second new role is the mental health practitioner, and obviously that is a 50-50 split with the Mental Health Trust. And I think discussions have progressed well on that, but we may see, and what we need to ensure is that all localities have access to those practitioners, and we may have gaps geographically which we need to address. So we're just looking at that at the moment. And also greater integration with community services, which has obviously started, and I think the COVID pandemic has provided an opportunity for PCNs to be really integrated across the system, perhaps far more rapidly in some ways than they might have done. And obviously that needs to continue. And finally, the Impact and Investment Fund, that continues in this year. We're looking at making the payments for 2020-21 once the data is finalised. There's only one change to that going forward, and that is for GP appointment mapping to be done by the end of June, the first quarter. And that's the only new indicator that PCNs have been asked to take up. I'm happy to answer any questions.
Can you just expand a bit about the GP appointment mapping, what it means?
What became clear over the past year is that the system's appointment coding doesn't really reflect the changes that have come about through the COVID response and the move towards digital appointments and triage and telephone appointments. So what practices are being asked to do is to look at all their appointments and start to assign them and make sure their coding is more appropriate to the model that's currently in place, so that going forward we've got a better overview of which appointments are used for which type of consultation, or whether it's used for a triage or telephone consultation, or indeed obviously taking account of clinical skill mix as well. So I suppose what this piece of work is setting the baseline for going forward.
I think that'd be good actually, because when I think we were presented with some data a couple of months ago about appointments, and I was scratching my head a bit to go, is this real in terms of the face-to-face and online, and actually at what point do you classify a clinician phoning you? Is that triage or is that an appointment? It wasn't really clear. So I'm pleased to see that. And actually it's really exciting to see the new roles coming through as well in PCN development. And presumably there's a bit of catch-up work as well to do for where PCNs have not been able to recruit to last year's schemes because those are still open. So there's going to be quite a lot of recruitment possibilities coming forward.
That there will be, that's right, and this has to be a real priority for this year, so that we do have the right skill mix in practices to support them with all the challenges that lie ahead.
Yeah, and particularly I think the seeing the mental health practitioners embedded in practice, and given everything that's in the news about COVID and the effect on mental health, it's really good to see. And hopefully there are other people out there to support us to do that work. Kathy, do you want to come in?
Yeah, sure, thanks. I'm wondering if in due course we could see a kind of, I mean, I'm guessing there's a sort of a dashboard somewhere of PCN development. And the thing that I find quite challenging really, I'm kind of looking at this paper, I'm looking at the workforce paper, and then I'm looking at the restoration paper, which says there's a chance that inequalities may be increased because of the capacity and resilience of each PCN, and taking these different elements in isolation I find quite difficult really. I mean, I would quite like to see how does PCNA, how are they doing in general in terms of the new roles and in terms of restoration and those kinds of things, because they're all related to each other. And I recognise that it's very early days. I recognise you're just, doing the maturity matrices now, but I would welcome something high level of that nature in due course, just so that we can understand where the risk really lies.
Yes, absolutely happy to provide that, and that's certainly something that we're working towards with the PCN plans. And absolutely, yes, there's a lot of overlap between the recovery and restorations, PCN development, and where all the different strands lie, and it's important that we don't lose any of that, and so it is important that we capture it all. So absolutely happy to provide that.
Sadie?
Thank you. I was just going to say that's actually very helpful for us, because when we're asking the individual localities to do their spotlight reports going forward, what we can ask them to do is to focus specifically on that, Kathy. So if we ask them to provide as part of their locality update something around their R's recruitment, their recovery, their maturity matrix, and their sort of focus around health inequalities, then I think, over the next few months, we'll get a good rounded picture for all of the PCNs for that, which would hopefully give you that reassurance.
Yeah, thanks. I would find that really helpful, and particularly if it had some, and this sits against a comparator across the piece of this, because what the difficulty I have with the with any spot report is that people often focus on the things they're doing well, which is fantastic, but it's very difficult to understand how good that is when you don't see it against the backdrop of other people's performance.
Okay, Jason, do you want to come in? Jason? Jason's disappeared.
Apologies, somebody just came to the door. It's fine. And apologies if somebody else has asked this question while I was just away. So it relates to the additional roles reimbursement scheme, and specifically for paramedics. The wording in the report implies that it's a must, but also that it's optional. And I just wondered, are we, if the PCNs do not take up the offer of the rotational scheme, are we effectively moving the problem of recruitment for those type of roles around the system? And The question is there a requirement for the PCNs to take up that rotation, or is it optional?
The PCNs have the option whether they wish to participate in the paramedic, the East of England Ambulance Service paramedic rotation offer. And if they want to partake of that, then obviously we will put in place the contracting arrangements that will allow that to happen. But they also have the choice to recruit paramedics independently. But I absolutely agree with you, and it's one of the reasons why East have come up with this offer, is because there is an impact across the system if every PCN were to recruit a paramedic at the required level. So there is a different level. If they recruit independently, it has to be at band 7. If they recruit through the rotational model, it can be band 6 because that is supported by East through their training development and clinical support. So it's a very structured framework which allows them to be, I suppose, in development for the higher banding role.
Thank you.
It's actually better for workforce development across the system as well, isn't it? So it's a win-win for everybody. Karen, do you want to come in?
Yes, please, Doris. It was along those lines, really. I know that the Ambulance Trust have some huge anxiety around depleting their services of skilled paramedics, and ultimately it is up to those individual paramedics. But the rotational role really offers opportunity and career development to the paramedics, and I think it breaks down a lot of barriers. So we're very, very keen on promoting the rotational role wherever possible. But I know that is a large concern for them.
Well, we can only encourage, and presumably if it's rotational, it takes up less resource in terms of recruitment, and because it's kind of planned. So we shall see what the take up is. Any other questions, comments? No. Thank you very much, Fiona, for the update, and we look forward to future more detailed information. On to the workforce and training hub. Are you taking that as well, Fiona? No, Claire's joined us.
Yes, I'm going to ask Claire to take this.
Thank you, ladies. I was primed and ready. So from the paper that Fiona and I produced for you today, you'll see the training hub strategy focuses on 4 priorities for us. So that's retention of workforce, recruiting to the workforce, which Fiona's already touched upon within the training hub and the workforce GP forward view umbrella, developing the workforce, and then those new ways of working which we've already seen throughout the pandemic, including the digital online consultation stuff. So they're the 4 priorities. An operational plan, training hub is no different to any other directorate or commissioning service. Maybe a lot of programs and projects have been placed on hold since I was last with you in November due to redeployments of workforce. So it's completing that restoration and reset operational plan moving forward for this year. Part of that will be myself completing a comprehensive training needs analysis, which supports more than just the regular training requirements for primary care workforce, such as your diabetes, your women's health, your respiratory, just as a snapshot, but having more meaningful discussion with practices this time round, and with PCNs around their individual workforce development plans, which should be based around last year's appraisals, individual discussions with their workforce, that local intelligence of their workforce, but not only that, their patient needs and requirements within their own practices. So the output of that will be a really deep valued training needs analysis that supports a workforce that potentially at the moment are tired, and just gives them that assurance that Training Hub and Workforce and GP Forward View programs are there to support them in their own needs and development. So with regard to budgeting, we haven't been given an indicative budget as of yet from the national teams. But with regard to Training Hub, I have been told that the indicative budget is due to be released, and then the formalised budgeting will be released in June or beginning of July today. I was told that, so that's hot off the press. And that's it from me.
Thanks, Claire. Thanks for the update. So do you expect sort of with COVID and people's roles kind of changed over the last year? Did you expect people, there might be some movement in terms of, because people's roles have changed, if they suddenly go, well, actually, this is the path I want to pursue rather than, the original paths that they're on. And so the training needs might be quite different from 18 months ago.
Yeah, absolutely, Doris. And that's exactly one of the reasons I want to have those real deep dive and discussions with individual practices to understand their needs. And not only that, I've been part of my redeployment has been supporting workforce throughout the whole ICS for the vaccination programme with regard to rostering and training. And because we've got the whole system and we've had a lot of people come from outside the NHS who are supporting, there's also a big piece of work to do which comes under the recruiting priority of retaining those staff. They've enjoyed working on the COVID vaccination programme, and they want to be part of the NHS. So it's ensuring, and we're working with the Health Education England at the moment to understand what are the needs of those workforce who perhaps don't have their English and maths, for instance. So we're going right down to our functional skills, to the care certificates criteria, and right up. And you're right, we also have general practice nursing who have gone to a more advanced level because they've been overseeing different clinics, whether that be COVID or they might be backfilling because another colleague is supporting COVID. So yeah, it's understanding those needs. And until I do that training needs analysis of identifying where everybody currently sits and what qualifications they currently hold, I can't completely give you that answer. But yes, we are. It's part of the recruitment priority for sure to retain those staff.
And it'll be interesting to see how that impacts on equality, diversity and inclusion agenda that we have in the NHS as well, and bringing people in from not from the usual sources.
Yeah, so we've had a lot of people from the army, for instance, who are very keen to come over into the into NHS. So yeah, it's very, and students who have predominantly perhaps not thought about health in the way they had before. It was all very much I'm heading to the acutes, when actually they've been working in primary care and thought this is a nice place to work. So yeah, it's retaining those workforce for sure.
That's great, thank you. Tracy, do you want to come in?
Yeah, my question was a bit in respect of what's just been said, but it's about kind of some of people have moved around doing roles, and it's just for the opportunity maybe not to go back to an old role completely, but still have that rotational opportunity, because some people having more of a portfolio, spending some time perhaps in community and primary care, it is quite nice for some people. Some people don't want to be in the same place all the time doing the same thing. So just think about being innovative and kind of how we can have roles that do spend time in different perhaps organisations, but part of an integrated care system. So I'm hoping that might come from your needs analysis when you do that, Claire, hopefully.
Yeah, I hope so, Tracy. And a good example there is our own CCG staff who have, especially the clinical team, have been absolutely instrumental in supporting primary care within the COVID vaccination programme. And actually our own CCG staff have all reported such positive feedback, how they're loving being back out on the ground, being really operational, having those rich discussions with their patient, with patients, and the practices. And actually, they'd like to do it sort of once a week. So yeah, that there is absolutely value in what you've just said. Yeah.
Fiona?
Thank you. And I was just going to pick up on that because I think part of the structure that's been put in place, we're working much more closely with ICS colleagues and the workforce team there, so that there can be a system level approach to how these roles are deployed, and also, as Claire said, and how and also supporting their training and development. So hopefully that close working relationship and will help to support that.
That's really good to hear, and I think some of it is also about people bringing learning from different organisations back into their, you know, wherever they are, and helping, you know, both organisations to grow and develop. So that's very positive. Are there any other questions for Claire? No, thank you very much. Thanks for the update, Claire. Thank you.
Thank you, Doris.
We move on to recovery and restoration. It's over to you again, Fiona.
Thank you. I mean, obviously, this is a key piece of work. There's absolutely no doubt that over the past year, primary care has changed in the way services are delivered. And whilst we look at recovery and restoration, I think it's really important that we look at it both from the perspective of a system level approach, so that we don't make changes in primary care that impact on secondary care, or vice versa, or other NHS services. The other part of that is some of the transformation that's happened over the course of the past year has been really beneficial. And so whilst we are looking to recover and restore primary care services, it's also important that we embed some of the good parts, the good transformational elements of that. And one of those things, of course, is having a mix of face-to-face appointments and online consultations that suit the local population needs. And that's something we need to be looking at very carefully. It would be fair to say that some patients have faced particular challenges over the course of the year in accessing primary care, and we need to make sure that those barriers are removed, and that we understand which groups of patients have faced those challenges, and ensure that they can be seen. And so some of the priorities that we need to look at is around learning annual health checks for individuals with learning disabilities and severe mental illness, those with long-term conditions who've perhaps not been seen in primary care. And importantly, we have to be able to understand the health inequalities that may have emerged over the past year and make sure that those are addressed, identified and addressed. And of course, critical to all of this is actually having a resilient and stable workforce. Some of the workforce that have been working hard over the past year, I think, will be feeling vulnerable and tired. And we need to make sure that anything that we put in place also supports them. And that's part of our workforce and training plans as well. That we're talking about with the ICS workforce team. I think there's also recognition that PCNs will be moving and practices will be moving at different pace when they look to recover and restore services. And we need to ensure that individual patients and groups of patients are not disadvantaged by this. So it's something that we need to work closely with our practices when looking at this. and how access to primary care is being opened up. And I think that's all I wanted to highlight, but I'm happy to take questions.
Tracy?
Yeah, I think as we're restoring service, I think it's being mindful about what the blend of appointments be, they face-to-face, telephone, virtual appointments, what that means from individual practice to practice, because it's going to be quite different. I think certainly where I work in an area of high deprivation, where I think we do have many patients that are digitally excluded, I've really noticed that we haven't seen people because we haven't been able to. We haven't really had contact with them because they are digitally excluded. And I think now we're seeing people, and I'm sure clinicians would appreciate this, we're seeing people with lots of problems, lots of issues, and they need a lot of time. So I think we just need to factor in with the restoration that certainly different practices have different demographics, different populations. In order to kind of address these inequalities, might need to have slightly different approaches and blended ways to how they deliver their care. And it might mean for some communities we go to communities perhaps. I think we can't rule anything out really to be fully inclusive and to address inequalities.
Thanks, Tracy. Andrew?
Yeah, speaking on behalf of Healthwatch here, I think we could offer you some help with the views of the public. We've had difficulty, like everybody, in communicating with people, but I don't know if you're aware, the footfall system has a button on it for public comment that comes back to the CCG, and there's been numerous, bearing in mind they're completely unfiltered and self-selected, comments from patients, which vary. Some are highly positive and some are extremely negative. But if I had to take a theme from it, it's communication. So there's been problems with communication of using IT systems, both by public and by practices. Trouble with the volume of phone calls, so expecting calls back and perhaps being delayed. Trouble with continuity, which bearing in mind that all our practices have had the same problems with people having to shield and work from home and so on that the rest of the country's had, and not everybody's IT systems are equal. So there's a lot to say, and I personally, I'm in perhaps a lucky position because I'm still doing GP appraisals, so I get that side of it, and I've also been doing doing the vaccination clinics. So I've actually had an opportunity to meet hundreds, if not thousands, of people for very brief, admittedly, conversations in a totally unscientific way. And the feeling is, from I'd say to compound it down, that it's become very difficult to communicate. That's the general feeling. A proportion of people find it really good and are extremely happy with new IT systems. But I fear to say we're introducing a new inverse care law here, because those people who find it really helpful are pretty much the people gathered around this meeting. So they're people with good IT access, good skills and knowledge, who may well at home have laptops, mobile phones, printers, scanners, and all the rest of the kit. And other people don't. And there's a real, I think, the real potential for losing people. And this is always acknowledged, but it's acknowledged and then everything keeps going. So we must acknowledge it and do something. Anyway, I don't want to go on too much, but just the other one is that the communication of new roles. If you speak to patients and the public and talk about social prescribers, or the difference between a paramedic that comes to you from the ambulance service and a paramedic that comes to you from the practice, most people won't know. And I think, I personally, I fully support the adoption of new roles, but have to communicate that well so the public know that the people they're seeing have a place in the overall system. Because I'm afraid too many people, well, lots of people, particularly perhaps older people, don't regard they only regard their GP and perhaps their practice nurse as counting, I'm afraid. So we've got to overcome that, and that's only by communication. So anyway, I'm offering Healthwatch to try and help with all the public view of all this.
Thank you, Andrew. Actually, that's very helpful. because I think that's always the danger with introducing a new system, especially during pandemic, where we've had to do things differently. But the danger is we end up losing the patients as we go along. So no doubt there's going to be a bit more work on patient feedback and how that influences service development as we go forward. I mean, we do need to move with the times, but on the other hand, we can't move and then leave half the population behind either. Rosemary?
I just really, can you hear me?
Yep.
Lovely. I just really wanted to concur with that point, Andrew, because we've been sort of getting some feedback from patients along the lines of, well, we haven't been able to see our GP for the last year, and now I don't want to be, and I'm using this in quotes, fobbed off with somebody else, and they see it as a barrier to getting to the GP. If we offer these other alternative roles, all of which are very valid, as we know, if we can't sell it to them, they just see it as a sort of another barrier to actually get to their GP who they've been waiting to get to for a year. So I think there is a lot of mileage in actually, as you say, selling the roles. I think it's really important because some of these roles are coming out of the secondary care sector, and for those people that are not familiar with that sector, they don't have the familiarity with the roles and the breadth of actual, knowledge that these people have. So I think there's work to do around that.
Thank you. Sadie?
Thank you. Just wanted to say a couple of things. Firstly, around the proportion of appointments, I think we're very clear, and the guidance on this that's come down nationally is very clear, that there needs to be a piece of work to determine the appropriate mix of appointments for a population. So it isn't just about, we've quite enjoyed working in this particular way, so we're going to carry on. It is around assessing the needs of populations, and as Tracy says, some areas will need to provide more face-to-face appointments than others. So I think that was the number one point, and we will need to think about how we do that, and I think there's a clear role for patient participation groups in all of this. I think the point Andrew raises, and backed up by Rosemary, is really important. And I've been around in the health service for quite a few years, and I remember going through exactly the same thing with nurses and nurse practitioners and phlebotomists and healthcare assistants when those roles were introduced. And I think, it's fair to say that over the last year, we've been through a massive period of transformation, but the transformation has happened without any patient and public involvement, which we would have normally done because it needed to be brought in overnight. And I think that's the bit we're now missing. We need to now take people on this journey with us, bringing in the new roles, bringing in the different ways of working, and understanding some of the challenges that patients experience as part of that. One of the we will be bringing in a dedicated communications and engagement officer into the comms and engagement team. They will be dedicated to workforce, new roles, and a little bit of primary care as well. And I think one of the things that we'll be asking them to do is really work with us on this, so that we can really have good information going out to the general public, but listen as well, as part of developing those roles, so that we can really try and go through that process of moving forward together, rather than just kind of implementing it because we needed to do it really quickly over the last year. So I think they're really excellent points, and it is something that we are very conscious of. Thank you.
Thanks, Sadie. James, do you want to come in?
Yes, I've just unmuted myself, and I agree entirely with what's been said before. Footfall is addressing the needs of the worried affluent well, which is disproportionately affecting the access for other patients who are not able to navigate the system quite so well. So I think there are some issues over all of that. How does it go? The big issue that we do have to do is a PR issue and talk to our patients about what the health service looks like now and what they can expect. We're receiving numerous complaints over what I would consider excellent service because it doesn't fit with their issues. I've had 3 complaints from patients in the last week since they were referred to queues, which used to be known as MECs, because they wanted to see a GP for their eye problem, but actually we've referred them to a fully trained optometrist with full eye examination equipment who can do so much for them, and they somehow think of that as being a secondary service. So it's, we're trying to, there's individual things that we're doing. So whenever we refer to somebody as MECs now, we're now sending them a follow-up text to reassure them that it is the right thing to do. But all of these all of these provisions, it sort of goes back to some 1980s, I want to see my GP within 24 hours, and if you're not giving me that, somehow you're letting me down. And we've got to engage and talk as a system rather than via individual practices, in my view. And I don't know what role this committee can have with that, or can it help inform NHS England or the CCG to have an honest debate, which is primary care services are now turning into a medical hub. It isn't your doctor, who's out playing golf. It's so different. We're rammed. We saw the stats from March, 14.8 million appointments in England in March 2021, by far and away more appointments seen than ever before, and yet somehow people still think we're closed. And I'm not sure what the answer is.
Thanks, James. Bill, do you want to come in?
Just a very quick point. I wonder if it's anything to do with the age demographic of the patients. And actually, the one thing we do know is how old everybody is. So, do we have to spend the same amount of time talking to everyone when we could pick a section of the population and have a debate with them, which didn't necessarily involve talking to everyone, if that would make it simpler or easier or quicker to have this. And if we concentrated all the effort on a particular segment, that may make it the problem easier to handle. That was just a small point.
Thank you. I think I'm not sure whether footfall is actually universally used across Norfolk and Waveney as well. So there are probably pockets where footfall is, people scratch their head and go, what are you talking about? So actually access is patchy. It's probably, I don't know what the percentage is of practices that have footfall. And so even though there is digital, it might not actually be available to everybody. And I think the last year, the patient engagement activities within the CCG has been curtailed along with everything else. And normally, we would be actually out talking to members of the public and stakeholders face to face. And I don't think that has been able to happen this year to partly explain the change, but we do need to do that catch up, and I think it's quite difficult when people are used to a certain type of service to change. People, as general people, we don't like change, and when we have change, we need to lead people through it so that they come along with us and not kicking and screaming. And they also need to see the benefits, because without seeing the benefits, they're not going to come along with us. So I always worry when there's a diktat comes out from Whitehall to say digital is the default, because it's not helpful. I personally don't think. But anyway, I'm off my page and my pay grade, so I better shut up. John?
Thanks, Doris. Just very briefly, just in response to what you asked there, it's about 85% of practices that use footfall, so it's the vast majority of them. And I think it's worth recognising, as you've said, that it was procured before the pandemic started, but then it was completely accelerated at the start of the pandemic and made a huge contribution to keeping services running. The digital team's now about to engage with primary care about where do we go from here, and I'm sure all the comments that have been made today about making sure we've got engagement with patients and the public are very relevant to that discussion about where do we go next, because clearly digital has a very important part to play in the future of accessing all services. It's just understanding what that place is, how that's best discharged, and how we make sure that people aren't left behind if they don't have access to digital. So I'm sure it's got a part to play, but there is a review that's going to take place soon about the future of that.
Yeah, that's good. I think the other danger is also, you know, with digital, you know, whilst we are complementous and able to make decisions and deal with technology, it's all great. But, you know, I've certainly seen members of my family who were highly digitally competent, and because of various illnesses, they slowly lose capacity to use technology, and then you're pushing people to be reliant on carers that they might not be happy to, you know, to be reliant on. So it's about patient choice as well, and recognizing that they are individuals within their own rights. I'm sure I'm preaching to the converted. So, are there any other comments, questions on this? Sadie?
Just to note that we are due a digital report at the next committee, so we should be able to get a good update on some of the discussion around footfall, etc. At the next meeting.
Thank you. If there is nothing else, we'll move on to any other business. Is there any other business from anybody? No. I think the with the sort of government roadmap of reopening, currently I don't think we have any plans to move away from Teams meeting for the foreseeable future, but we are sort of looking into options going forward. But we're likely to be on this lovely screen for another few more months. So you're all spared to having to see me face to face. We have questions from the public. We did receive one question from the public. I'm just going to I thought I printed out the question, but I hadn't. There was a question from the public regarding the West Norfolk small interpretation contract. And I know that Fiona is in the process of drafting a reply, because it is a historical arrangement for a GP practice in West Norfolk regarding asylum seekers. So once that Fiona's managed to find the information, that will be posted onto the website and also replied to that person in as well. Is that correct?
Yes, thank you. I just need a little bit more information before I could respond completely, and I want to make sure that the reply is accurate. So yes, within the next day or so.
Thank you. I don't think there are any other questions from the public received during the course of this meeting. I'm sure Sarah will tell me if there is one, but I take silence as no.
Yeah,
so
no, nothing at all.
Thank you, Sarah. So thank you all very much for this afternoon, and I look forward to seeing you all digitally in June.